Hello, and welcome to our lecture on chronic pulmonary dysfunction. This is one of two lectures that we're focusing now on cardiopulmonary health. In this case, primarily a pulmonary condition that is going to have some influence also on the heart. After numerous weeks related to looking into the neurologic system of the human body, it'll be nice to try to just switch gears and instead look at both lungs and heart to see how they're functioning related to this particular clinical condition. That being said, we also have to get a lay of the land, like we did before in our first sections related to stroke, to appreciate regions of relevant anatomy and different ways of its assessment. It'll be a completely different direction for us where we've been looking at neurology for such a period of time. And let's try to make sure that we can build upon that to have a better sense of how pulmonary, primarily, as well as cardiac-based changes can occur in this clinical condition. So related to the outline for today's lecture, we're going to review the anatomy and physiology of the lung. Beyond just lung anatomy, we want to also appreciate lung volume terminology, because this gives us an idea of whether the lung is working at an effective level or if there may be a pathology that's present. And that gives us a better understanding of things related to the different physiological elements in the matching of perfusion to ventilation. These are two terms we're going to be going over soon. We also want to take the understanding of what is lung function and consider that in terms of the presentation of chronic obstructive pulmonary disease. So, similar to what we've done previously, we're going to want to highlight the epidemiology of this particular condition, discuss the etiology, consider or overview the pathology as well as what it includes. The pathology of chronic obstructive pulmonary disease includes both chronic bronchitis and emphysema. These are two different aspects to the pathology, but we might find them together in a presentation. Having an understanding of both is important. And from there, we're looking to look at some of the primary subjective and objective symptoms that a patient may present with related to chronic obstructive pulmonary disease. So when reviewing over the respiratory system anatomy, the system can be divided into three main portions. There's the upper airway, and this consists of nasal cavities, your sinuses, the pharynx, tonsils, and the larynx. And then there's the lower airways that are below that, and that consists of two different parts. One section that is deemed as a conducting airways, and the second section is dedicated to air exchange itself. In looking at the three different portions, we can appreciate that each one of these plays a specific role related to the anatomy of the respiratory system. Now, in coming into this course, you may already have an appreciation of the respiratory system, just from previous courses that you've completed. So, let's do a little bit of an exercise. We're going to take the opportunity to arrange the different aspects of respiratory anatomy that I present here on the screen. And we're going from air entry to the location of gas exchange. So with that in mind, I'm going to bring up on the screen here different items. Terminal bronchioles, alveoli, bronchus, alveolar sacs, respiratory bronchiole, bronchioles, distal respiratory unit, trachea, and finally alveolar ducts. Now, these are put up here in no particular order, but in looking at some of these terms, you may already have an appreciation of the order they should be in. Or, it's a little bit hazy for you, but you think you have an idea of where we should start to finish. And take the opportunity now, pause the presentation, take out a blank sheet of paper, and arrange these different items from air entry to location of gas exchange. And when you come back after pausing the presentation, we're going to review over the order and see how close you got it. Welcome back. So, we can all appreciate that the role of the use of lungs is to bring in air, arguably oxygen. And we're looking at ventilation that's going to be playing a role. There's specific terms related to ventilation, and we're going to touch upon that in a moment. But first, let's go over the exercise at hand. We want to try to begin from air entry all the way down to exchange. So the first section we're looking at is the trachea. From there, we're going to be leading into the bronchus, which then will lead towards bronchioles and terminal bronchioles. And we're going over these different sections because COPD will affect different regions of the lung. And that's dependent if we're talking about chronic bronchitis or emphysema. So being able to break down the lung is important in that sense. Let's appreciate that the bronchioles are a bit more proximal than the terminal bronchioles. And that's one way we might be able to remember them in terms of the order. From the terminal bronchioles, we're going towards the respiratory bronchiole, alveolar ducts, alveolar sacs, and finally the alveoli. So as we go from the more proximal to the more distal, as we progress further and further down into the lungs, we can then proceed to separate the sections out into different regions. This lower section right here is more so termed sometimes the distal respiratory unit. And what makes it unique is that there's the presence of alveoli in this region, and they play a very specific role. Within it, we expect there to be components that allow for gas exchange to occur. So now that we have an appreciation related to lung anatomy, and in looking at how the presence of alveoli in different regions of the lung can separate out lower sections from upper sections, let's now consider physiology. So lung function or physiology is comprised of both ventilation and respiration. These are not the same thing. Ventilation is the ability to move air in and out of the lungs via a pressure gradient. Respiration is the exchange of gas that supplies oxygen to the blood and body tissues and removes carbon dioxide. Respiration doesn't occur in all regions of the lung. Ventilation, moving air in and out of the lungs via pressure gradient, can be found in other regions. But respiration requires specific anatomical structures to be present to allow for the exchange of gas in the form of oxygen and carbon dioxide. So when going over the physiology of the lung, let's appreciate that there are various terms that we have to touch upon, because when we measure lung physiology, there's certain values or levels that can be measured. So, for example, at full inspiration, if you take a deep breath right now, the lungs contain their maximum amount of air, and this is called total lung capacity. Now, this total lung capacity can be broken up into separate sections. By dividing it into 4 separate volumes of air, we can look at the different components of total lung capacity. One of the volumes that we're talking about is tidal volume. So if you're just breathing, normal breathing, no increased inspiration or expiration, what you're at is what is known as tidal volume. You take in some exterior air or oxygen, arguably, you blow out carbon dioxide, and it's at a particular level of lung physiological work. If you take in a deeper breath or inspiratory reserve volume, that would be extra air beyond tidal volume into the lung. If you're at a normal breathing level and you decide to breathe out all the air that you have within the lung possible, that is your expiratory reserve volume that you're breathing out. But even if you breathe out all the air you possibly can, there will still be some air trapped within the lungs. And that remaining air that's still stuck in the lungs, even when you try to breathe everything out, we term as residual volume. The amount or components of measured volumes, when taken all together, makes up your total lung capacity. And depending on the proportion of these different volumes, it might demonstrate good physiological function or the presence of underlying pathology. Now, to complicate things a little bit further, we don't just look at volumes, we also look at capacity. A combination or two or more of these lung volumes we talked about are termed capacity. And we, again, will put these different volumes together because this is something that we can measure, which will also reflect on whether there's good physiologic health in the workings of the lung, or if there could be a pathology that's present. So capacity that can be measured, for example, would be the inclusion of tidal volume and inspiratory reserve volume. This is termed inspiratory capacity, or basically how much you can bring in as a whole. Your expiratory reserve volume and your residual volume is termed functional residual capacity. And tidal volume plus expiratory reserve volume and inspiratory reserve volume is vital capacity. So you could argue that vital capacity is all the air you're possibly able to manage at a normal level of breathing, deep breath in, deep breath out, everything you can, with the exception of residual volume. Now that we've gone over lung volumes and capacities over the last couple of slides, it's a good idea to review over things again, but if we could, with a visual representation. So let's appreciate that on the left, we're having a bit of a visual representation of the lungs in action, and on the right, we've got different ways of breaking up how the lung is working in that sinusoidal waveform that you see, and where we can break it up into different groups. So first off, let's appreciate that we have tidal volume, which usually is shown as TV, but here sometimes is shown as VT. It's the amount of air that we've found in normal breathing, and you can see that it's relatively in the middle section at a low amplitude of breathing in and breathing out. If you take a deep breath, that's going to be your inspiratory reserve volume that you're drawing in. It's the extra air inspired beyond tidal volume. If you put those two together, tidal volume plus IRV, inspiratory reserve volume, you have the inspiratory capacity. Looking at another section here, we have our expiratory reserve volume, and that's the extra air that's exhaled beyond tidal volume itself. So you breathe out forcefully. You have residual volume, which is the air left after maximally exhaling. So you can exhale as much as you wish. This is still going to be the amount of air that is trapped within the lungs. If you put those two together, you're going to have what's known as your functional residual capacity. Short form is FRC. And that's the air that's remaining in the lungs after tidal exhalation. So in tidal volume, you breathe in, you breathe out naturally. If you're breathing out at a rest rate, there's still going to be some air that's left in the lungs. And some of that will be the expiratory reserve volume, the air you can push out further if you forcefully breathe out, as well as residual volume, the air that's in the lungs you can never get out. Putting this all together is our total lung capacity. And if you wanted to, you could take your total lung capacity here and split it up a little bit more in the realm of vital capacity, which is inspiratory reserve volume, tidal volume, and expiratory reserve volume, as well as the remaining residual volume that's here. So now coming around to a new concept called forced vital capacity. The vital capacity is the inspiratory reserve volume, tidal volume, and the expiratory reserve volume. We can assess this to get a sense of the physiological function of a person's lungs. So if we were to assess the patient's ability to take in a deep breath, and then from there to breathe out all that air forcefully, as denoted by A going up and B going down through there, we would receive a value that is deemed as a forced vital capacity. And dependent on the patient's performance of that forced vital capacity, we may note the presence of pathology. So similar to what we did earlier in the lecture, where we took the opportunity to just review over some of our knowledge in the realm of lung anatomy, let's do the same thing in terms of lung physiology. We're looking to assign the correct definition with lung capacity terms. So, for what we reviewed over the last few slides, take the opportunity now, and if you can, challenge yourself so you don't look at your notes, and link up the items on the left side of the screen that are dedicated to terms of volumes and capacity to what they represent found on the right side of the screen. Pause the lecture right now, and I'll be with you in a moment or two. Okay, let's see what we have. Inspiratory capacity, that is tidal volume plus inspiratory reserve volume. Residual volume is the air that's left after maximally exhaling. Tidal volume is the amount of air for normal breathing. Expiratory reserve volume is the extra air exhaled beyond tidal volume. Vital capacity is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So it's the total volume of air in the lungs that we have under our volitional control. Functional residual capacity is expiratory reserve volume plus residual volume. It's the air that's remaining after just tidal exhalation. So if you breathe out at a normal rate, there's still going to be air that's within that's made up of both expiratory reserve volume and residual volume. Which means, finally, inspiratory reserve volume, which is the extra air that's inspired beyond tidal volume. So as we've discussed on a couple occasions, we can measure the flow of air that goes through and out from the lungs. So if we were to measure the flow rates, we're kind of measuring the volume of gas, in this case air, arguably oxygen in, carbon dioxide out, that's moved in a period of time. And if we measure the amount of gas that's moved in that period of time in and out for the lungs, we're using that as a reflection in terms of the ease with which you can ventilate your lungs, or you can get air within the lung and out of the lung. And this is arguably related to the elasticity of the lung parenchyma. So one of the key terms related to that is elasticity. And that elasticity will become compromised related to COPD, chronic obstructive pulmonary disorder. In case you're curious about parenchyma, it's the substance of the lung that's outside of the circulation system that is involved in gas exchange. And it does include the alveoli and respiratory bronchioles. So it's where gas exchange occurs, which is very relevant in terms of the purpose of the lungs. One way to measure this flow rate is consider the patient's ability to participate in FEV1, and this would reflect the status of larger airways. So what's an FEV1? Well, it is the first important airflow measurement that we like to look into, and in this particular assessment we have a machine that would allow for, first off, the patient's nose would be plugged, and we're looking to see through the tube that they're able to breathe into and out of the overall airflow that can be measured. So the FEV1 is forced expiratory volume in 1 second. So in healthy individuals, we expect that within 1 second, someone can forcefully expire about 75 to 80% of their total FVC. Now, let's remember that FVC is short for forced vital capacity. That's your inspiratory reserve volume, tidal volume, and expiratory reserve volume. Yes, I know I'm going over different terminology related to volumes and capacities back and forth. If need be, feel free to go back over the PDF that I'm putting into OWL or going over the slides just to help yourself to remind yourself. There are different ways that we can measure, and they're made up of different capacity and volumes. Take the time to just make sure you're comfortable with these ideas. In following up with the FEV1, let's appreciate for the majority of individuals in this kind of flow diagram that in the first second of this forced vital capacity maneuver, which means you breathe out all the air that you've taken into your lungs. So in this example, it would be 3 liters of air is measured in that first second of what would be the forced vital capacity of 4. So over the course of 1, 2, 3, 4 seconds, notice this change in this curve. If you take a deep breath in and you breathe it out, we would expect the majority of that air will be expelled in 1 second. And then if you keep going, you're quickly going to peter out to less and less and less measured flow. So in this particular example of forced vital capacity of 75%, that would be approximately about 3 liters. And that's what we expect it to be. In a pathological condition, that's not always the case. FEF 2575 is deemed as the second most important airflow measurement, and it will reflect the status of smaller, more fragile airways. So the FEF is the forced expiratory flow rate, and it's in the middle of the forced expiratory flow volume curve. What do I mean by that? Well, it's the average flow from the point at which 25% of the forced vital capacity has been exhaled to the point at which 75% of the forced vital capacity has been exhaled. So we're looking at the average flow from one point of time to another. Going from here, say that's arguably the 25% mark, to the 75% mark. How quickly is that rate? Is it happening relatively quick, or is it happening a little bit slower than one would expect? So changes in the lung or chest properties due to aging or disease can affect your lung volumes, your capacities, but also your flow rates. Not just how much you take in, but also your ability to breathe out. So changes in flow rates of smaller airways, and it would be more likely to be shown here with your FEF 2575. If you have changes in flow rates of the small airways, it could be a precursor related to development of COPD. So it may reflect changes from a pathological standpoint. So now that we've gone over lung volumes, capacity, and ways to try to measure it, let's try to integrate that together with some of the anatomy that makes up the lungs and appreciate where we have regions where we can have respiration occur, or whether it's just ventilation itself, and how that may be relevant in terms of pathological presentations. So first off, notice that we're going to be very high related to the lung anatomy. We're here in the tracheal region. And in so starting, first let's appreciate that there is actually muscle in this region. Here we have the trachealis. It's smooth muscle that is found throughout the bronchial tree. So it's not just in the trachea, it can be found lower down as well. And its role is to try to decrease the diameter of the trachea when it contracts. So where it continues on through the bronchial tree, it can be found in terminal bronchioles, a little bit in respiratory bronchioles, but by the time you get to the alveolar ducts, sacs, and alveoli, this muscle is no longer present. So appreciate where we have a lot of respiration and gas exchange, there is no muscular contraction affiliated in that region according to the anatomy. A few other things of interest in this region related to anatomy is the lamina propria. So it's between epithelial and submucosa, and it contains elastin, which allows the trachea to stretch with inhalation, recoil with exhalation. And also nearby, we have goblet cells in the epithelium that produce mucinogen. And this becomes hydrated to form a protective mucus on respiratory epithelium for trapping airborne particles. Now, one of the reasons why we're going into the depth of this particular area of anatomy is that this can change with pathological presentations. So case in point, here we have a scanning electron microscopy which shows a mucus gland duct opening into the airway epithelial surface. So it's basically a gland that is open and healthy and working as one would expect. Keep this in mind as we go later on in the presentation, because we're going to think of how this duct may look in the realm of chronic bronchitis, a component of COPD. Moving on from the trachea, we're now going to be going a little bit more into the lung itself proper. And when looking at the lung and its anatomical makeup, as we might have over here, we can expand it further into a region here where we have terminal bronchioles, which will branch off to respiratory bronchioles, and that will in turn shift over to the alveolar ducts and the alveoli. So this is where we really start to see the transition from what is just ventilation to respiration, or the area of gas exchange. So to break that transition down a little bit more from an area that is dedicated to ventilation, which is where there's the movement of air or gases, to a region of respiration where gas exchange happens within the body, let's start here at the very top. And this is our terminal bronchiole. Now notice around it we have a few different aspects. There is smooth muscle that is there. There is cartilage that is there. And it is primarily involved in allowance or promotion of movement of air further down or further out of the lungs. It's a transition zone. As we transfer further down into the respiratory bronchioles, we can appreciate that in this region here we have a mucous membrane, and that can be found in multiple regions of the lung. Further, as we transition to the alveoli, appreciate that this is where we have a direction of blood circulation that's connecting into here. This is your pulmonary artery. So it is deoxygenated blood that's coming to the lungs purposefully to pick up oxygen that's being brought in by the lungs, and that's being done so at these alveolus or air sacs. So we're going from a normal lung near this terminal bronchiole, where we're allowing for ventilation to occur, down into this lower section where we can see that with the use of blood circulation and its connections and the alveolus that are here, this connection is primed and well designed for an efficient gas exchange. So once more, an appreciation of this terminal area of transfer of respiration or gas exchange that can happen. Look at the alveolus and how in depth all these capillaries are around them. So the capillaries, it makes sense. The greater the amount or the healthier the capillary bed that is present, the better this perfusion will occur. And also, there's elastin that are found in the connective tissue here of the alveolus, and this is allowing for an elastic recoil. So the reason we're bringing this up, first off, we appreciate that yes, the capillaries are part of the circulatory system. They surround the alveolus and are attached to the pulmonary arteries. They are directly involved in gas exchange between the lungs and what will be the heart. The alveolus are designed to expand and contract with every breath you take, and they're able to do so effectively via the elastic recoil found by elastin connective tissue that makes them up. Capillary bed health and the presence of elastin in the alveolus are two areas of concern when we look at emphysema. Emphysema is more likely to affect the more distal or outer regions of the lung that are involved in gas exchange. Chronic bronchitis is more likely to affect the more proximal or medial structures that are involved in ventilation of air related to the lung. So it's in that context that we can appreciate these previous few slides that show what anatomy should be involved in and how, in pathological conditions, this may change as we discuss COPD in a little bit further depth. So in discussing the anatomy, let's move a little bit into physiology because we're talking about this air or gas exchange a little bit more so. And I've touched upon now circulation, so I don't want us to be lost in terms of the connections that are present. Let's appreciate that we have here capillaries that are going to connect in with the alveolus. And if we zone into this zone, we're going to find where oxygen will come from the alveolus, where it's collected there in the lung, to the capillaries, and CO2 will come from the capillaries out into the lungs. Makes sense. We breathe in, we bring in oxygen, it's going to be picked up. We breathe out carbon dioxide, that's brought over from the capillaries. That's the overall view related to function. In breaking things down a little bit more, also appreciate that we have within the lungs macrophages, which are designed to just aim to clean up the lung where at all possible. And here we have also this interesting green thing, which is a surfactant cell. Surfactant cells are involved in keeping the alveolar walls from collapsing during expiration. And again, if I'm highlighting some of these anatomical features, it's probably also in the sense that they could be compromised related to pathology. So, as we appreciate across this respiratory membrane, O2 and CO2 move across so as to allow for this important site of gas exchange to be functional. So in discussing further pulmonary anatomy, we can't continue on with that without discussing the blood supply. The capillaries that we showed on the previous slides are relevant in terms of gas exchange with the alveolus. So it would be a good idea for us to review where those capillaries come into play in terms of gas exchange and how that is related to the heart, to further appreciate on how the heart might be affected by things such as pathological presentations. So from here, in terms of the flow, this diagram can be a bit busy, so let's follow some numbers in terms of where we're going. We're going to start here in the right atrium, and that's going to be located on the left side of your screen right here. This is going to contain deoxygenated blood, or arguably blood that has CO2 within it. If we follow the right atrium, we go down to the right ventricle, and from there we're going to be going up to the pulmonary trunk. So going down and then ascending. From here in the pulmonary trunk, we will split to both a left pulmonary artery and a right pulmonary artery. So these arteries, in so going on, will travel into the lung where eventually they will lead to a pulmonary capillary, or a small branch of circulation that connects intimately with the air-filled alveolus of the lung, allowing for gas exchange, CO2 leaving the capillary, going into the lung, and oxygen coming from the lung and going into the pulmonary capillary. That's the reason why yes, generally when we talk about veins, we talk about something that's blue, containing deoxygenated blood when we talk about that in the arms or the legs. But in the lungs, it is the exact opposite. Here we have a pulmonary vein on the left side. Here we have a pulmonary vein on the right side, and note that because they contain oxygenated blood, they are actually red in color. The oxygenated blood will continue back to the heart, where it will go into the left atrium, from there continuing on to the left ventricle, and finally up into the aortic arch, where it will in turn transcend out into various important parts of the human body to provide oxygenated blood for a myriad of different physiological functions. So here's a schematic of what we just discussed there in terms of pulmonary and circulation interactions. So we have a right atrium that goes to the right ventricle. The right ventricle will in turn go to the pulmonary trunk, and we'll have right and left pulmonary arteries going to these arterioles, which are arguably smaller arteries, and finally capillaries to connect to the alveolus. This is known as your pulmonary circuit. Once the capillaries come in contact on the alveoli and the lungs, there will be this perfusion that occurs, and that is where gas exchange occurs from alveolus to the capillaries and back and forth. So we're basically going from a circuit that is low in oxygen but high in carbon dioxide, so O2 poor, CO2 rich, to what's known as the systemic circuit, and that's on the lower half of the screen, where once you have oxygenated blood, it will then go on to your right and left pulmonary veins, the left atrium, ventricle, and finally to the aorta, just like we discussed. That's a bit of a visual representation of what we discussed on the previous slide. Nice for a review, but also highlights a little bit more on a couple of relevant points. First off, the contrast between the two. The pulmonary circuit is going to be O2 poor and CO2 rich. The systemic circuit, however, will be O2 rich and CO2 poor. Another thing we want to keep in mind is this right ventricle. It's relevant because right ventricle hypertrophy can be a feature in pathological presentation. Just because you have a lung-based pathology doesn't mean it just remains to the lung. The heart is interconnected intimately via circulatory supply. So if lung function is affected, that in turn can affect heart function. So now that we've had a chance to go over the anatomy of the lungs, the interaction between both lung as well as circulatory system and how that intertwines related to the heart, let's now delve in a little bit more towards this ventilation and perfusion in terms of matching. So ventilation is again where we have air that's going to be moving through the lungs, and it is gravity dependent. So most of the inspired air is distributed to a part of the lung that's going to be closest to the ground. Blood distribution is even more gravity dependent. So in standing, more blood enters vessels in the bottom of the lung than the upper part of the lung. So where both you rely on gravity when it comes to air going into and out of the lungs, as well as in terms of where you're going to have the greatest concentration of blood, we're looking at trying to match these together to get the most efficient air exchange possible. This matching of ventilation to perfusion increases the lung's efficiency in gas transport. So we're looking at how effective that can be performed, and in a little bit, how that may change related to pathology. Now, how pulmonary arteries engage and interact with the alveolar tissue is not just static, they're dynamic. And the basis of how arteries can engage, whether they vasoconstrict or vasodilate, is based around the availability of oxygen. So delving into that, when pulmonary arteries vasoconstrict, this will increase pulmonary artery pressure. When pulmonary arteries vasodilate, this decreases pulmonary artery pressure. Now, that would make sense because if you have vasodilation, you have opening, and that will in turn reduce the overall pressure of an artery. So arteries can dynamically shift from vasoconstriction to vasodilation based on factors. The most important cause of pulmonary artery vasoconstriction is low oxygen content in alveolar gas, which means oxygen that's not readily available. This is a mechanism to ensure efficiency of the lungs. Let's go into this efficiency a little bit more. We're talking about alveolar hypoxia, and hypoxia is a deficiency or reduction of oxygen, and shunting blood to match ventilation to perfusion. So ventilation and perfusion are trying to match up effectively. You want to get the most effective air exchange possible. Gravity plays a role in that, so you would expect where gravity is going to pull and assist in the pulling in of air. It also affects blood flow, and if we can match that up efficiently, that's going to be of benefit. Now, pulmonary artery vasoconstriction, which we talked about on the previous slide, is utilized to try to deal with alveolar hypoxia in one lung segment. That means a reduction of oxygen. So you're reflexively shunting blood from the lung segment to another, more well-ventilated lung segment. So if there is hypoxia in the alveoli, you're going to then thereby vasoconstrict the pulmonary artery, and that's going to shunt blood to a well-ventilated portion of the lung. There's no purpose in keeping a vasodilated blood flow around a region of the lung if it's not as efficiently providing oxygen. Instead, shift it elsewhere. This improves lung efficiency by better matching well-ventilated lung areas to well-perfused areas of the lung. It's a well-matched ventilation to perfusion ratio. And we're bringing this up to first appreciate that shunting blood to match ventilation to perfusion is a normal phenomenon. This happens in your lungs all the time because you change positions. You lay down for sleep, you stand up vertically for standing and walking. So oxygen and how it goes into the lungs will be affected by gravity. Blood flow will also be affected by gravity. And the body is constantly trying to ensure that the most efficient ventilation to perfusion ratio is being maintained. Now, that can be thrown off related to pathology. Here we have a simple diagram, but it's a good representation of what it is that we're talking about. So related to this normal ventilation perfusion matchup, here is our airway. Oxygen comes in from the pulmonary artery. We have deoxygenated blood, or high in CO2. Oxygen is picked up and thereby to the pulmonary vein, which is here in red. It is oxygenated blood. Not a bad way of representing what it is that we've been talking about. Now, finally, after talking about lungs, the anatomy, how to measure their physiological efficiency, leading further into this ventilation perfusion matching, we get to touch upon pathological presentations. We're looking at 3 abnormalities on the next slide, where ventilation is not well matched to perfusion, where we have an impaired ventilation, a blocked ventilation, and an impaired perfusion to ventilated area. We're doing this to first appreciate at the lung level itself, if we just break it down to how ventilation matches up with perfusion, or how the presence of oxygen in the lung is able to match up with blood supply that's designed to pick that up. If that's compromised, then what can occur? What can we visually see that may occur as a result? Because if we can appreciate that better, we're taking the first steps to appreciating the influence of the pathological condition of COPD. So let's look at those 3 scenarios related to abnormal ventilation perfusion matching. So in scenario A, here we have impaired ventilation. So appreciate how, again, oxygen will come in. There's no limitation here. There's some limitation here, and that can limit the ability of these alveolus to expand effectively. So the oxygen content here is different than the amount here. So circulation is going to shift to maximize a good perfusion to where we have the greatest amount of oxygen. Here, we will oxygenate blood. Here, we will not. It's similar in scenario B, but here it's even more distinct that this area is blocked. So again, there isn't oxygen that's able to come down and in. This region won't expand, and the body will adjust circulation flow to promote it to go around where we have the maximal amount of oxygen that can be available. In scenario C, you have a pretty clear pathway for both, but here the perfusion itself is compromised. So again, because it hasn't matched up well, not because of what is happening for the oxygen intake, but because circulation to the site is compromised, once again, only within one will we have this oxygenated blood. So when looking over the scenarios where we have abnormal ventilation perfusion matching, in scenario A, it's an inadequate ventilation of a well-perfused area of lung, which means that the amount of oxygen that is able to come down is compromised, but the blood flow is still pretty good. An example of this would be in bronchospasm and asthma. And we're going to be talking about that more in the next lecture, but for now, appreciate in this scenario, your ventilation is low compared to your perfusion. And perfusion can be visualized in the short form in this Q. So we have V/Q is a discussion in terms of ventilation to perfusion matching. In scenario B, you have no ventilation, and it's still a very well perfused area of the lung. There's still blood flow that's going there, but you're not getting any air exchange. So this can occur where we have a collapsed alveoli, where the alveoli itself has been damaged. This would be a scenario, for example, in a collapsed lung that could occur due to trauma, or if the area is filled with fluid proximally. That could be seen in chronic bronchitis, where you have a buildup of mucus or fluid that completely blocks the area. So you have very low ventilation, but again, perfusion is okay. In scenario C, you have poor perfusion of a well-ventilated area of lung. You're getting oxygen down to the region, but the area's circulatory supply is compromised. An example of that is obliteration of the vascular bed by chronic destruction of alveolar wall in emphysema. Chronic bronchitis and emphysema make up COPD. In one, we have very low ventilation. In the other, you're going to have decently high ventilation, but poor perfusion. Now moving into chronic obstructive pulmonary disease, sometimes known as chronic obstructive pulmonary disorder. Short form, COPD. And please notice I've underlined obstructive because it can be acting as one of the markers for identifying somebody who has this clinical condition. It's made up of two major components. Chronic bronchitis is one of them, and that's where you have the presentation of a chronic cough and expectoration, which persists for at least 3 months over 2 years. Expectoration would be you're bringing up something, mucus or some other form of quote-unquote gunk that the patient will say they have to clear out of their lungs. And it does persist for a decent amount of time, at least 3 months over the course of 2 years. The other half is emphysema. This is an abnormal enlargement of the distal respiratory unit with destruction of the alveolar walls. We're going to go into a little bit more detail related to that. But appreciate that these two diseases are an aspect that can be found in COPD. What I mean is the two most common disease processes that contribute to COPD can often coexist and be together. And the clinical signs and symptoms of them tend to overlap. It's not uncommon that one of these will lead to the other, they link together, and we're going to find the presentation of both with patients in this condition. We are starting to see a shift of COPD becoming a greater amount of rising global burden. So by that, what I mean is it's increasing in terms of mortality. So over the course of the last 30 years, going into this year, COPD has jumped from 6th to now 3rd overall in terms of global burden. And mortality is the condition of being dead. That's the definition of it. So there's an increased risk of death due to COPD over the course of the last 30 years. Morbidity is a condition of being ill, deceased, or unhealthy. And from there, we start to see the shift of COPD down here at the 12th position, and also jumping up over the course of the last 30 years to 5th overall. So unlike some conditions which maintain their position, if you look here related to mortality, cerebrovascular disease, still 2nd overall. There'll be others that have shifted down. COPD and other associated aspects, for example, lung cancer, seem to be shifting in an upwards trend. So going into COPD epidemiology, 4% of men and 5% of women have self-reported COPD. They say that they have some breathing difficulties, that they have a chronic ongoing cough, that they will frequently spit something up or have an expectoration. But if we did some lung functional tests, we would find that the populace as a whole, it's not around 4 or 5% that actually have COPD. It's around 17% based on airflow obstruction. So when we were talking earlier in the lecture, and we were showing that sinusoidal wave that goes up and down, and you can measure inspiratory reserve volume, and you can measure tidal volume and expiratory reserve volume, that would demonstrate compromise in 17% of the population, even though only 4 or 5% expect that they have COPD. It is underrepresented in terms of the total view of the populace. More people have it than they know. Symptoms of this disease are not usually seen in people under the age of 50, and we note that the prevalence of COPD tends to increase with age, which leads to the next question: what can we say about COPD from an age and gender perspective? The correlation between age and gender is of interest related to COPD. In starting at the age of 35 and ascending up there in age, we actually find that from 35 through to 64, it is more prevalent in women than in men. From 65 to 74, the difference starts to close, and then above the age of 75, there is a significant shift, more so to men than in women. So in regards to the prevalence of COPD by age, it varies by sex. So under the age of 75, COPD is more prevalent in women, and over the age of 75, COPD is more prevalent in men. So going into the etiology, why is it that COPD is actually caused in the first place? COPD, according to the Global Initiative for Chronic Obstructive Lung Disease, short form is GOLD, is defined as a preventable and treatable disease. COPD is airflow limitation caused by chronic inflammation of the small airways and air spaces in response to significant exposure to noxious particles or gases. So going over a little bit more related to the etiology, the chronic inflammation caused by irritation, one of the main causes is inhaled cigarette smoke. It is the major causal agent in COPD. 80 to 95% of COPD cases is caused by cigarette smoking. That is significant. Now, there's a direct relationship between the amount and duration of cigarette smoking and severity of lung disease. In childhood, exposure to repeated respiratory infections and secondhand smoke may predispose to COPD in later years. So it doesn't necessarily have to be that you choose to smoke. It may also be the environment that you grow up in, if it's also associated with respiratory infections. There's other factors that might come into play. Occupational exposure to toxic agents. So if you work in an environment where there is dust, where there is chemicals, that's one possibility. Air pollution can also put individuals at greater risk of development of COPD, and so that could be region dependent, in that some regions of the world have a greater amount of air pollution, others less so. And also the genetic hereditary deficiency of alpha-1 antitrypsin, also known as AAT. In case you're curious, AAT is a protective protein made by the liver. So the role of it is to destroy enzymes that digest damaged cell and bacteria in healing process before the enzyme will continue on to attack healthy alveolar tissue. If you have a genetic deficiency, this causes low concentration of alveolar AAT. And if you have low concentration of alveolar AAT, you cannot destroy enzymes that are naturally part of the lung environment and prevent them after they've digested damaged cells or bacteria in the healing process. You can't prevent them from continuing on to attack healthy alveolar tissue. So there is a genetic link for some individuals to be at higher risk for development of COPD. So where it makes up 80 to 95%, how about we focus first off on a patient who has for a long period of time been a cigarette smoker. COPD changes, or the pathogenesis that we're looking at, can be found throughout the pulmonary system of this individual. It can be found in the airways and in the pulmonary capillaries, which means it can affect ventilation and perfusion. Chronic inflammation, where we have increased macrophages, T cells, neutrophils, will result in damaging of the endothelial lining of airways. It can narrow airways and result in damage to fragile lung parenchyma. So we're going to break down COPD pathogenesis, and we're going to do it in looking at both chronic bronchitis and emphysema. So starting at the top here, someone who smokes, so they're smoking cigarettes, or let's say they're in a realm of where there's a fair amount of air pollution. In looking at the progression and how these two things will differ, we have two different processes that are beginning to develop. If you're smoking, you're likely to have continual bronchial irritation and inflammation. So those tubes, the bronchioles that are going down, that are not involved in air exchange, but they are involved in the ventilation, the movement of air, start to become inflamed. And with that inflammation, if we stay on this left side, over time, this bronchial irritation and inflammation will cause chronic bronchitis. Itis is inflammation. Chronic bronchial inflammation, also known as chronic bronchitis. You'll also have bronchial edema, so you have some swelling that will be there. You'll have a hypersecretion of mucus, and we'll explain why in a few slides. You'll have that chronic productive cough. Why? Because you have too much mucus. Your body's trying to get rid of it. And you can also have bronchospasm, where the bronchial walls, because of the smooth muscle that's there, the irritation that's there, will begin to spasm or adversely react. The muscles will get tight. They get irritated. So we're seeing that on this side here. If we go even lower in the lungs, though, where we have our ventilation to perfusion, where we have our alveoli, where we have gas exchange happening, well, this area has a lot of elastin. When you breathe in and breathe out, this region expands and closes. Elastin is in alveoli and it lets that happen. This elastin, because of the smoke, will start to break down. And that breakdown will result in what's known as emphysema. You have destruction of the alveolar walls or the septa that's there, and the airway becomes a bit more unstable. You're not having good expansion and contraction like you should. In some cases, you'll have expansion and it just won't contract again. The result of these two processes will lead to airway obstruction, air trapping, dyspnea, frequent infections. We'll be discussing that a bit more. And that will lead to an abnormal ventilation perfusion ratio, kind of like we talked about before, hypoxia, hypoventilation, and even right heart failure. So we have these two processes where we'll have a pathological process in the bronchioles, a pathological process in the alveoli. There will be two different mechanisms of what's known as air trapping, altered ventilation perfusion ratio, and we also have this interesting development where there's also going to be influence on the heart in a clinical condition known as cor pulmonale right ventricular hypertrophy. So going over the pathological changes that are involved in chronic bronchitis. Once again, let's consider a patient who for a period of time has been smoking cigarettes, and with that smoke that's coming into the lungs, it will result in irritation and inflammation of the bronchial tree. This causes proliferation of the inflammatory cells and hyperplasia. So hyperplasia is an enlargement of an organ or a tissue. So hyperplasia of large airway mucus glands and smooth muscle cells. And as a visual representation, we can look here on the right. So normally there should be a ratio of a mucus gland of 1 to 3. If you look below in chronic bronchitis, mucus glands will grow, and they're doing that because of the ongoing irritation secondary to cigarette smoke that's coming into the lungs. That's foreign material. The body is trying to get rid of that, trying to collect that. And if it's doing that for a long enough period of time, it will undergo hyperplasia, meaning the body says, okay, there's still this ongoing foreign material. I have to accommodate to that. I need to get the mucus glands to grow more. And that way try to utilize mucus as well as cells that are involved in inflammation to clean up and clear out the foreign material that's coming in. The mucosal inflammation will eventually destroy ciliated epithelium, substantially diminishing mucociliary clearance and narrowing of the lumen. Translation for that, we rely on ciliated epithelium. So we rely on these little hairs, these little means of cilia that can assist in the upward clearance of mucus. But over time, if the area becomes further and further inflamed, the cilia starts to reduce and becomes destroyed. Mucus now can't be cleared as readily. It starts to collect. The mucus glands that are now growing via hyperplasia, where they're starting to have more cell turnovers. Hypertrophy means there's an increase in the size of cells, so they're taking up more and more prominence there within the lungs. We're starting to secrete more mucus to the point where there's a hypersecretion of mucus. And the bronchial smooth muscle becomes hyperresponsive to this stimuli. It starts to spasm more. So you're getting more mucus. There's more inflammation. You don't have cilia to clear it out. And bronchial smooth muscle around there starts to get more and more irritated to that. With all this mucus and bronchospasm, you're going to lead more and more towards chronic airway obstruction and impaired clearance of airway secretions. So if you go all the way back to our ventilation perfusion matching, remember when we discussed scenario B of an obstruction, a blockage? This is why it happens. You get mucus that's built up. You have a bronchial spasm that will close down. There's no air that's able to get within that particular section of the lung. Pathological changes that are involved in emphysema. Again, our patient, who is an ongoing cigarette smoker, they're going to be bringing in this foreign material smoke into the lungs, and tobacco smoke inactivates the normal process of alveolar repair. If you consider that your alveoli are going to be active every time you're breathing, there's going to be some turnover. There has to be some maintenance. Tobacco smoke actually inactivates this process. So as a result, you have the breakdown in the elastic connective tissue in the alveoli. Your elastin is starting to break down. This loss of elastic presence in the alveoli causes a decrease in the overall elastic recoil and an increase in lung compliance. So there should be an expansion and a return to normal size. An expansion and return to normal size. You're no longer having that. So this removes normal support for non-cartilaginous airways. In case you're curious, non-cartilaginous airways means those airways that are involved in air exchange. Early on, we went over the anatomy. We talked about how you would have bronchioles and terminal bronchioles, and they're just involved in ventilation. They have cartilaginous aspects that make them up, but the alveoli don't. So they really don't have support like other parts of the airway because they don't have cartilage nearby. They're relying on elastin that is now broken down due to the presence of tobacco smoke. So in a normal lung, if you were looking at a peripheral airway, that would be the example of it. But the airway related to emphysema has just here collapsed upon itself. Its integrity is no longer sound. So this contributes to airway instability and premature expiratory collapse of the airway. So a loss of alveolar walls causes enlarged air spaces with loss of alveolar capillaries. Your perfusion is no longer patent. The walls, because of this collapse, will result in a loss of perfusion, which will lead to dyspnea, progressive irreversible airway obstruction, and abnormal gas exchange. So this is scenario C of the abnormal ventilation perfusion matching that we talked about earlier. So here we're looking at normal, healthy lung parenchyma. Parenchyma is a term for the functional portion of an organ, the section of the organ that really is involved and important in doing some of its very relevant work. So here we can have an appreciation related to the alveoli. And here we're looking at the destruction of alveolar walls affiliated with emphysema. Notice how the number of connections and air pockets are altered. The air pockets are much larger, and as a result, that will break down the surrounding circulatory connections and alveolar capillaries that should be there. So now that we have a sense of what is made up for COPD in terms of chronic bronchitis and emphysema, how does that compare from a functional standpoint in terms of overall lung function? Well, during normal inspiration, the lungs and the airways are pulled open, increasing the diameter of the airway. That makes sense. You take a deep breath, and you're going to feel that expansion. Also, during normal lung function, we look at expiration, and in that, as the thorax returns to a resting position, the airways will decrease in size. You breathe in, things expand. You breathe out, things will contract. That makes sense. Now, in patients with COPD, during inspiration, the airways are pulled open by thoracic expansion, allowing air to enter. But during expiration, the airways are narrowed by inflammation, remodeling, secretions, and as a result, they can close prematurely. This traps air in the distal airways and air spaces. So instead of breathing out air, some air is actually retained. So let's go over how this air trapping can happen related to chronic bronchitis. Above, we're more proximal, below, we're more distal. So appreciate that we have air that's going to be going down to the alveolar wall region. And up here represents where air exchange doesn't happen. This is in your bronchioles, for example. Now, this red right here, we have some inspiration airway that's coming through, allowing for enlargement. It's bypassing this red object, and that object is a mucus plug. So there's been mucus that is built up due to irritation, like we talked about on the previous slides. When air comes in, it moves past this plug. The problem is, during expiration, the plug now shifts. The airway narrows, airflow closes the mucus plug against the airway, and it's now trapping air distal to the mucus plug. So now the air is staying in. This mechanism of air trapping is called ball valving, and it's where the alveoli take up their size, more so as a ball, and if you were to place a valve at the very top, everything would be trapped within. Here's the thing, air trapping doesn't just happen with chronic bronchitis. If we know that chronic bronchitis is affiliated with mucus production, we can make sense that there will be some trapping there. But there could be some air trapping as well in emphysema. So normally on expiration, the alveolar elastic recoil pushes air through open bronchioles, which means you take a breath in, it's going to stretch the alveoli, and then with expiration, that stretch is going to be gone. Elastin will recoil, and that will force things out. That's improving lung efficiency. That said, if the alveolar walls are damaged, you can't hold the airway open and you lose elastic recoil. So damage to the walls here means that the underlying elastin isn't present the way that we would like, and they collapse, and there is no elastic recoil. And as a result of these two factors, we're going to have some air trapping that's going to remain down here in this region, and that's also affiliated with emphysema. So now moving on to COPD, dyspnea, and lung volumes. In case you're curious, dyspnea is the medical term for shortness of breath. On the left, we have the representation or relationships of lung volumes that we were familiar with earlier on related to healthy lungs. So we can appreciate there's inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volume. Now appreciate, if we look on the right related to COPD, that inspiratory reserve volume and tidal volume are exactly the same. Expiratory reserve volume, though, presents as smaller, and residual volume is much larger than compared to somebody who has a more so normal lung presentation. So what you're seeing here related to COPD, if we were looking at lung functional tests, is a presentation that's largely due to hyperinflation. You have those small airway collapse from emphysema that we discussed in the previous slides. We know that alveoli can't empty out if there's excess mucus that's there to plug the air from getting out. And as a result, we're going to have this hyperinflation where your expiratory reserve volume is difficult to breathe out residual air. ERV is how much air you can breathe out from a forced expiration, but your expiration is difficult to get out because it's being plugged. And in emphysema, the airway collapse will also have hyperinflation. So your ERV is reduced because you can't clear the air further, and your RV is increased because of all this air that's trapped within. The lung functional tests have changed, which is why these functional tests can be used to assist in the diagnosis of COPD. So why would we do a lung functional test in the first place? That usually comes around to somebody who is presenting with various symptoms of COPD, and their health provider feels that performing lung functional tests would be warranted. Now, symptoms of COPD, they may come on slowly. We know that an individual can have emphysema and some small airway obstruction that can occur, and that is again affiliated with, say, tobacco smoke or something of that nature. And we know that that will progress to lung hyperinflation and will have increased amount of trapped gas that will be there. Eventually, it will present to the point in time where you have some emphysema, you have some air that's trapped within the lungs. It doesn't compromise you. And then you're going to have some shortness of breath, initially with exertion. You may feel that you're just out of shape. And then your exercise tolerance starts to become less and less. With hyperinflation, it becomes uncomfortable to try to participate in exercise. Your tolerance is reduced. It's harder to breathe. It's harder to breathe out effectively. And that's going to affect your overall tolerance related to exercise. This leads to immobility and deconditioning. Your muscle mass becomes less so. Your ability to perform activities is limited, and this can lead to a poor health status. Now, that was looking on the left side related to emphysema. Consider what might happen here with the mucus hypersecretion related to chronic bronchitis. Now you've got cough and mucus, and this cough and expectoration, it can appear slowly and insidiously, just like we highlighted here. This may come on a little bit slower. Many smokers may have no airway obstruction initially, and they'll smoke for years without compromise. But down the road, as it's used more and more, then the obstruction starts to become more of an issue, and they feel they have to cough more and clear their throats more and clear their lungs more. As COPD progresses, inclusion of emphysema, chronic bronchitis, and you may notice there's going to be some overlap. We know there's overlap with air trapping. Well, as it progresses along, you can have shortness of breath at rest. This is where somebody needs to undergo some lung functional testing to find out what's going on. Besides the presence of shortness of breath, as well as cough or expectoration, there's other things that we can find if you were doing a physical exam of somebody who has COPD. The thorax, and that would be the chest region, appears enlarged due to hyperinflation and loss of lung elastic recoil properties. So the anterior posterior diameter of the chest, so if you look from the front to the back, it will look increased. And there can be a dorsal kyphosis. So kyphosis rounding up over top, the chest is larger. They look almost like a barrel chest, where the chest itself has expanded with so much air that's being trapped, it's expanded out to the shape of a barrel. Their thoracic mobility becomes limited. They have difficulty bending, twisting, or moving in the chest and mid-back region, as well as the accessory muscles may be recruited based on the stage of the condition. Remember the accessory muscles we discussed way back in spinal cord injury on how you can have the diaphragm, but you have other muscles like your traps, like your SCMs, your sternocleidomastoids, that will be involved, scalenes, that will be involved in bringing in more air, more oxygen. They will have to kick into gear in some of the further stages of the condition because of the difficulty of trying to get oxygen sufficiently in where it's still some that is trapped. Auscultation of the lungs. That's a complicated way of just saying take out your stethoscope and listen. You're going to notice first off a reduction in breath sounds. So breath sounds would be in and out. There's an expectation that if you place it against a normal lung, you will hear that. Because the lungs are hyperinflated, it's harder for you to really pick up those breath sounds. And that's partly because it's difficult to take in a full breath, difficult to expire a full breath. It's harder to hear. And if there's an area that's partially obstructed, like the bronchus or bronchioles due to mucus, you can actually hear a wheeze or a musical whistling sound. There can also be the presence of secretions within that region that will result in crackles or popping or result of intermittent bubbling of what's in there. In the advanced stages, besides just what you can hear related to lungs, you might see there's certain activities that the patient will aim to do, such as pursed lip breathing. And that's where the person, when they breathe out, instead of just simply breathing out, they will purse their lips as if they are going to whistle, but they're not making a noise of whistling. They're pushing out air. And they're doing that because it allows them to blow out more carbon dioxide and overcome some of the mucus, some of the air trapping issues by forcing with their lips a pathway to blow out the CO2. Cyanosis would be seeing bluishness, for example, underneath the fingernails. That may highlight that the circulatory supply of oxygen is also being a bit compromised. And digital clubbing is also present there. Why that happens is unknown. We query whether there's going to be growth factors that are secreted by the lungs. That's one suggestion as to why it happens. But what's involved is where, if you look at your finger right now and put it right in front of you, you'll notice where the finger ends and the nail begins, there's a small slope down. In digital clubbing, that slope's not there. It just goes straight across. The nail looks elevated. It looks like it's been hit with a club. So now that we have a better sense of the symptoms of COPD, how it may present on lung functional tests, even the physical examination that one might expect, there's one more thing to touch upon, and that would be that in advanced COPD, there is a significant likelihood of cor pulmonale, also known as right heart failure. So if we look at the flow here on the right side, in chronic hypoxemia, we're going to have increased pulmonary artery pressure. That will result in hypertrophy of smooth muscles in pulmonary arteries, and eventually chronic pulmonary hypertension, leading to cor pulmonale, hypertrophy, and dilation of the right ventricle. Let's explain that a little bit better. Starting first related to chronic hypoxemia. We know that if we have progressive destruction of the alveolar capillary bed, there's going to be the chronic reflex of vasoconstriction of pulmonary arteries due to hypoxemia. The reason for that is, like we discussed before, the body's smart. It's going to try to match. If a region doesn't have oxygen readily available, then the body's going to shift around blood flow to another region where there can be good perfusion. Now, if it has to do a lot of this because of progressive destruction of the alveolar capillary beds, if that's getting more and more dominant, then this is going to lead to increasing pulmonary blood pressure. Usually you're going to have enough ways where your blood can flow, but if some areas are destroyed from an alveolar capillary bed perspective and you're shifting now blood into less and less available tubes, those tubes are now going to have an increased amount of pressure. So that's going to lead to eventually stiffer arteries to try to manage the increased pressure that's there. So you're going to have hypertrophy of the smooth muscle in the pulmonary arteries as a result. And that's going to contribute to chronically increased blood pressure. The right ventricle now has to work harder against this increased resistance. So that right ventricle that's involved in pumping blood into the lungs is now going to undergo hypertrophy. But there's now this reduced oxygen supply because of the lung disease. Right heart failure can then follow. And this is where eventually the right chamber of the heart has lost its ability to pump effectively. And if there's now an underlying cardiac condition, that can lead to other medical concerns. So coming to the end of our lecture related to COPD, as a bit of a summary of things, let's again appreciate the primary cause of COPD is cigarette smoking. There are two coexisting pathological processes in the lungs. We learned that chronic bronchitis is a bit more of a bronchial pathology, and it's where we have the production of more mucus with our reduced ability to clear it, and that's going to result in an abnormal ventilation-perfusion ratio where we have reduced ventilation. If the mucus is sufficient enough, it's going to obstruct it completely. In emphysema, it's an alveolar pathology. It's further in the periphery of the lungs, and that's where gas exchange occurs. And with the loss of alveolar walls because of elastin being affected, this is going to lead to the loss of also alveolar capillaries. So as a result, you are going to have abnormal ventilation perfusion again, but you now have reduced perfusion because the capillaries are no longer patent. In related to COPD, cough and expectoration are common symptoms, but the major symptom that is something that the person is going to then say, I need to see somebody about this, I need to see my doctor about this, is likely going to be the shortness of breath, the dyspnea. And that's because it tends to be related to things such as immobility, deconditioning, as well as poor health status. And it's there that when following up with the health professional, that there can be further testing done related to assessment of the patient's posture, performing auscultation, inquiring about how they breathe. Is it pursed lip breathing? Is there cyanosis? Is there digital clubbing? And all those things will come in for us to suspect the presence of COPD. And that may lead further to now we need to do some lung functional testing to confirm if COPD is present, and from there consider further medical management.